KEYNOTE-189 was already published in New England Journal of Medicine and has shown a benefit in terms of overall survival, progression-free survival, and response rate when chemotherapy with cisplatin and pemetrexed was combined with pembrolizumab, and this was irrespective by PD-L1 status. In the recent years, there are some evidence suggesting that tumor mutational burden on tissue and on blood can help to select patients with immunotherapy single agent or immunotherapy with a combination of anti-PD-1, anti-PD-L1, and anti-CTLA-4. So until yesterday, there were no data for TMB for the combination of chemotherapy plus immunotherapy. So this was the objective of the exploratory analysis that was presented here. TMB was assessed by whole exome sequencing, and two analyses were performed. One analysis was conducted by using TMB as a continuous variable, and the second analysis was performed by using two cutoffs. One cut point was 175, and it was identified because could approximate 13 mutation per megabase with Foundation 1. The second cutoff was 150, and it was approximately 10 mutation per megabase by Foundation 1. The results were very interesting because they demonstrated that TMB in patients treated with chemotherapy and immunotherapy is not a good biomarker for the selection and for patients to receive either chemotherapy alone or chemotherapy plus immunotherapy. The hazard ratio for overall survival, progression-free survival, and response rate are always of the same magnitude in the three endpoints with also the different cutoffs. So TMB for the selection of chemotherapy and immunotherapy, it seems not to working like for single agent and anti-CTLA-4. So the situation for TMB is quite complicated because we don't know yet the right cutoff, the right technique, whole exome, Foundation 1, to do the test on blood, to do the test on tissue. What we know is that on tissue is very difficult. In all the studies, there was an attrition rate of about 50% for the small amount of tissue and that yielded just a small amount of DNA. On blood can be another option, but I think that we have to work if this is a good biomarker, maybe to select patients for immunotherapy, single agent combined with anti-CTLA-4. A good opportunity can be in PD-L1 negative plus, but this is again research, because for PD-L1 negative nowadays, the only possibility that we have to increase the survival of our patient is chemotherapy plus immunotherapy. So this scenario now is quite complex. We have several biomarkers. We have to work on how to harmonize all the tumor mutational burden and to try to personalize the treatment for our patients.